I do want to get into this value question. And simplistically, it's often been a position where the manufacturer takes the noble stance that their value is innovation. And what they're doing is bringing that innovation to impact favorably the lives of patients. The provider takes the noble position of the caregiver, and they're responsible for treating those individuals and having to address the balance of efficacy and toxicity in order to get the best outcomes for their patients. The payer is interesting because they've also often been assailed by the others of the stakeholders, but they take the nobility position that they're the only adult in the room, and they're the stewards of the healthcare dollar, and somebody has to say no, or has to be able to make that cost-effective comparison to say, we not just have this patient, but there are thousands of patients, and not just with cancer, but with heart disease and diabetes that we have to think about, and we have to make these hard decisions, and there has to be an adult in the room. But we don't often hear from the patient. And so when we hear about whether it's a cost story and an innovation perspective, or a more clinical efficacy and toxicity, what would you say, and both, I guess, personally and in the advocate's role, is the position of the patient when trying to address what is the value to them?
So from a value perspective, like, we're all about length of life. For the most part, we are willing, especially in the younger metastatic population, we are willing to sacrifice a great deal of toxicity and quality of life to make it a little bit longer. And we put up with a lot of really debilitating side effects, and we navigate the financial toxicity aspect of this as well, attempting to find grant monies and pharmaceutical support when it comes to the ability to pay for these CDK4/6 inhibitors, which are incredibly expensive. On average, my drugs cost around $12,000 a month, and Medicare doesn't cover all of it, obviously. So the value is really based on our ability to live longer, and hopefully that next medicine comes out so we can actually continue to see our children grow up and continue to do this advocacy work that we are so passionate about. I mean, if I'm being honest, CDK4/6 inhibitors have saved my life. I am on my first line treatment, Faslodex and Ibrance, and I have been without evidence of disease for the entire time. So there's no question that I wouldn't be doing what I'm doing if it wasn't for that drug combination. I'm very grateful.
When you talk about the advocacy, and it was very personalized, which is often a problem for medicine because that would be considered anecdote, and we can't look at the individual. We have to look at the large population. But as an advocate, you have to look at a large population. You have your young patients, but you also have your older patients and patients who are in their 70s and 80s with breast cancer. And how do you, from an advocacy role, is the advocacy fairly specific and straightforward, and it's strictly about length of life, or there's different needs for different people, and as an advocate, we're trying to express all of those?
So I personally support around 6,000 metastatic breast cancer patients, and everything from 18-year-olds to 93-year-olds that are living with the disease. The needs are very different across that span, and not just based on age, but age is a really big divider when it comes to how people see the world, and as far as what things they value in their treatment process. So as you get up the chain a little bit, it tends to be more about quality of life and managing things like the neutropenia, the peripheral neuropathy, which is not something we hear a lot about, but it is something that does happen. And really being less tolerant of the toxicities that come around with these sort of drug processes. And they also tend to be a little more heavily pre-treated as well. So when I poll my friends or my supporters out in the world, I try to really gather everything that they want to be represented when I'm talking to researchers or to oncologists or to people that I encounter at these various different conferences around the country. And the value definitely shifts more toward quality of life as you get up the ladder in age.
I've participated on cancer decision-making for payers. I've been involved on 2 different national payer panels. And it's interesting because I think that as a provider, you there tends to be some animosity towards payers. You think that the decision-making isn't sound, but understanding how payers address what is medically necessary and not experimental is critical. But in both panels that I was on, although we had a lot of physicians and physicians broadly representative of the network of providers, we didn't often have patient advocates. And I'm curious, how do payers address that? And it is difficult. And Kelli, to be frank and honest, for me, it's often very hard to have some of the hard clinical conversations when there's a patient advocate at the table, because I feel that people lose their candor. And it's difficult in front of someone who's struggling with the disease to sometimes be frank about, there's only so many dollars, or I appreciate your perspective, but the clinical trials, even though that drug is working for you, it wasn't impressive in terms of what it offered, given its cost and other factors. But Steve, are payers trying to incorporate the patient perspective more, and how do they do that?
Yeah, so Bruce, we work with Susan G. Komen, both in terms of financial support and ongoing dialogue through our plan and our foundation, cancer support communities, which is around survivorship and nutrition and psychosocial support of persons on his cancer journey. So certainly it's a voice that is important. Our plan sponsors, which of course, Bruce, you're very familiar with that notion, which would be an employer group, and they have a perspective on the person, the human being, the employee, his or her dependents. So that's another part of the voice of the patient, and certainly how the advocacy groups interact with the major professional organizations, whether it be ASCO, whether it be NCCN, whether it be San Antonio, and so that comes into the fore as well. So there's a lot of different places where the voice of the patient is heard. You referenced certainly the way that we would approach the looking at evidence. That said, we know that oftentimes, I think the general number for all FDA approved drugs is about 30% are used out of label or off label, which is perfectly legal for physicians in the United States, and cancer is probably maybe approaches 50%. Again, I defer to the clinicians on that. So that's something we're well aware of. There are prior authorization for expensive therapies, and they tend to be associated with both the Food and Drug Administration label, but also major authoritative organizations like NCCN and ASCO and others, NCI.